identification of sick child, stabilization, and transport. So usually a sick child, sickness is not usually perceived by the mother and sometimes by the bystander, especially younger age. And they may appear sleepy or drowsy. And you have to take proper history from the mother to know whether the child is actually sleeping or the child is sick. So you have to observe the activity and the feeding behavior of the child and the physiological categorization. So as you all know, the physiological categorization, the A, B, C, D, E will help in identifying the whether the child is sick or not. In the COVID scenario, you all may be familiar with the symptoms suggestive of COVID. So they may come with the fever and non-specific symptoms and respiratory symptoms, distress, failure, or GIT symptoms. They may come with the GIT symptoms like diarrhea, vomiting, abdominal pain, and circulatory failure, shock. Then CNS, more and more cases are coming now with CNS manifestations like altered sensorium, seizures, raised intracranial tension, and acute encephalopathic syndrome like presentation. And see, all these presentation may be even in acute COVID as well as in MISC situation, you can see all these problems. So there is a quite overlap in the symptoms. All the symptoms may be present during acute COVID as well as in MISC. So most of the time in MISC also, the history of fever and previous COVID may not be there in most of the cases. And they may be, sometimes we may be thinking of acute COVID. So you all may be familiar because already you have two classes and all may be familiar with the categorization, and you have to refer cases who are belonging to the category C. So you should be familiar with the symptoms of category C, that is the inability to feed, decreased activity, lethargy, and altered sensorium, seizures, breathlessness, respiratory distress, cyanosis, hypotension. So they can present with the respiratory manifestation, circulatory dysfunction, neurological dysfunction, or any non-specific symptoms. So you have to be familiar with these things. Any children who is having these symptoms should be carefully looked into whether they are belonging to category C and given treatment and stabilize the child and sent. So stabilization is very important. So seeing category C cases and referring alone may not suffice. The most important thing is stabilizing the patient at their institution and referring subsequently. Prompt referral and transport. So these are very important. So the MISC cases also can be mild. You may be seeing non-severe cases of MISC, and that can also sometimes lead on to severe. So initially it may be with a mild manifestation of MISC. So you should be familiar with the all the manifestations of MISC. Sometimes the child may come with less severe manifestation like rash and conjunctivitis and conjunctival hemorrhage and or GIT manifestation. And sometimes they will come with or they will progress. Children with the mild manifestation may progress to circulatory failure, shock, and neurological dysfunction, encephalopathy. So all these things. So the MISC, all the manifestation should be of the MISC. You should know. I think the classes have already been taken. This is just introduction. So you should be familiar with all the symptoms of acute COVID as well as the MISC. Most of the time, the symptoms will overlap. So whatever it is, if it is a category C, or even if it is a MISC, which is not it's going to severity, also you should refer. So in a COVID scenario, a child can become sick due to respiratory problem like pneumonia becoming severe, ARDS. Cytokine storm also can produce respiratory failure. And the circulatory dysfunction. So because of respiratory failure, the child can go for circulatory dysfunction and shock. And cytokine storm due to acute COVID as well as MISC can lead on to circulatory dysfunction. Neurological, both acute COVID and MISC can produce a neurological dysfunction and non-specific symptoms. So you can get two scenarios. One scenario is child is admitted in your hospital with the category A or B is deteriorating. Another scenario is a sick child is brought to the hospital in the casualty. So the physiological categorization is very important. It will help in assessing the physiological status to identify whether the child is sick or not. So it's a systematic approach. So I may not be going to, like very that is very as in a pulse class. So but so the physiological categorization will help you to identify whether the child is sick or not, how much is the severity, and how to intervene and stabilize the patient. So you have to assess the physiological status. These everybody know: airway, breathing, circulation, neurological status, and exposure. That is head to foot examination. So this is the pulse this thing. So the cardiac arrest is the commonest cause of death. As you all know, cardiac arrest. It is commonly in children. It is due to a respiratory problem, and the respiratory problem will lead on to respiratory failure, then cardiopulmonary failure, and death. So in COVID, acute COVID also, you can get arrhythmias, and very rarely you can get arrhythmias, especially in older people. Adults only you will get arrhythmia. In children, usually you will get a respiratory failure and circulatory dysfunction. So the importance is that the respiratory arrest or the respiratory arrest is usually the survival is much better when compared with the cardiopulmonary arrest. So it's important that you should prevent the cardiopulmonary arrest by managing the respiratory failure or respiratory distress, respiratory failure, and circulatory dysfunction. It's a very important slide because even a child with respiratory distress, you should be very careful, because it is you are getting a golden chance so that the child is not going into respiratory failure and subsequently circulatory failure and cardiac arrest. So even a child with tachypnea or respiratory distress is very important, and they should be managed appropriately. And this is the initial impression, that is the pediatric assessment triangle. This is on looking at the child, what do you feel? So the appearance, work of breathing, and circulation to the skin, the color of the child. So this will the aim is to detect the life-threatening condition. Are we dealing with a life-threatening condition or not? So if the child is having an abnormal tone, increased flaccidity or increased stiffness, the child is not looking at you, and the breathing is irregular or apnea, bradypnea, the circulation, the child is motile. So the initial appearance, breathing, and color of the skin, that will tell you whether the child is having a life-threatening problem. So the life-threatening problem can be related to the airway. You can get a complete or severe airway obstruction. Breathing can be an apnea, significant work of breathing, bradypnea, no detectable pulse, poor perfusion, hypotension, or unresponsiveness, depressed consciousness. So hypothermia, bleeding, petechiae, purpura, abdominal pain, distension. So all these, any of these, if you are getting, that's a life-threatening situation. So suppose a child is coming with unresponsive, with no breathing and only gasping. So you shout for help. This is the diagram from pulse. So shout for help and look whether the child is having a pulse. So if the child is having a pulse, and then you open the airway and begin ventilation. And even after giving ventilation, the pulse is less than 60 and there is a poor perfusion, you go to start CPR. And if there is no pulse also, you start CPR and go to the pediatric cardiac arrest algorithm. And when the child becomes better, you can evaluate and then identify and intervene appropriately. So you have to evaluate the child, you have to identify the problem, and you have to intervene appropriately. So it is done by primary assessment, that is A, B, C, D, E, and secondary assessment, focused history and examination, and you investigate the child for finding out the cause of the problem. So the airway breathing usually will be, it will be dealt with Dr. Jayakrishnan after my presentation. So I will just go through. So if the airway is not maintainable, you have to maintain the airway by chin lift or jaw thrust. And you should know what is, you should look at the breathing, whether the child is, what is the respiratory rate of the child, what is the respiratory effort, all these things. And you should know what is the normal. It will be given as a chart, and you can display at your consultation table. And the respiratory rate, what is the respiratory rate? Is it having tachypnea? Is he having respiratory distress? Is he in failure? So all these things you have to find out. My topic will be mainly how to deal with the circulatory failure and stabilize the child and then transport. And the breathing, airway and breathing and oxygen therapy will be dealt by Dr. Jayakrishnan. So circulatory failure, when you will say that the child is having circulatory failure, you can think of pulsus paradoxus or arrhythmia. Then central peripheral pulse difference. You have to look at the central pulse, the carotid or the brachial in an infant, and it's compared with the distal pulsation. So usually it is 3 plus and 2 plus. And so you have to assess the central pulse as well as the peripheral pulse. So and you have to assess the capillary refill time, and usually if it is whether it is more than 2, that is 3 or more, is abnormal. And cold extremities, you look for the peripheral circulation and look at the BP. So we have to assess the neurological status by assessing the sensorium of the child. Is the child having seizures, and what is the pupillary response? So altered sensorium in a child can be due to you cannot differentiate when a child comes with altered sensorium whether it is he has gone developed altered sensorium because of hypoxia or hypercarbia, or the altered sensorium, that is the encephalopathy, has resulted in hypoxia and hypercarbia. So it's a vicious cycle. So exposure, that is very important. Head to foot examination, so that is very important, especially in the MISC scenario. Should look for rashes, should look for conjunctival congestion, conjunctival hemorrhage, oropharyngeal congestion, and Kawasaki disease like presentation. And you should look for any other features of MISC and features of other illness. Sometimes can present with circulatory dysfunction or a MISC like situation when the child have toxic shock syndrome, dengue fever, or scrub. So to look for the features of other illness. So we'll go to a case scenario. So this is a 3-year-old fever, 2 days, and you should look airway, breathing, circulation, and CNS, and you have to do the GRBS, and the temperature also you should take. And you have to categorize the child, whether the child is having a respiratory distress, respiratory failure, circulatory failure, or he is having an encephalopathy. So regarding circulation, you have to look at you have to take the heart rate and rhythm. Is it regular or irregular? To feel the both central and peripheral pulses, and capillary refill time, and skin color and temperature to look for the peripheral circulation, and the blood pressure. So these values should know about what is hypotension. A baby less than 1 month, less than 60 systolic BP is hypotension. Infant 1 to 12 months, less than 70 is hypotension. And children 1 to 10 years, 70 plus 2 into age. If it is less than that, that is the 5th percentile. Less than that, it is hypotension. And any child more than 10 years, less than 90 systolic BP is hypotension. And normal heart rate is there in pulse, that is awake rate and sleeping rate. And this child, the circulation is 3-year-old child, circulation heart rate is 150 per minute, regular, and peripheral pulses weak, central pulses are also weak, and capillary refill time more than 3 seconds, periphery cold and pale, and BP is 80 by 40. The child is having hypotensive shock. So what is shock? Shock is decreased oxygen delivery to the tissues is affected. So it can be due to a decreased cardiac output, or it can be due to a decreased arterial oxygen content, or the increased metabolic demand. So you have to know what is the cause of shock, because only knowing about the cause of shock, you can manage the cause. You can treat the cause of the shock, and you can stabilize the patient. So it can be a hypovolemic shock, that is there is a fluid or blood loss, so diarrhea, vomiting, and there is a trauma, and dengue fever. All these conditions you will get a hypovolemic shock. Cardiogenic, when there is a myocardial dysfunction, you get a myocarditis or cardiomyopathy. All these situations, or a heart disease, that there is a left ventricular failure, you can get a cardiogenic shock. Metabolic, the cardiogenic shock can also be due to metabolic, that is hypocalcemia, hypoxia, acidosis, that can also result in cardiogenic shock. And distributive shock, that is a increased vasodilatation. So the periphery, the system, vasculature is dilated, so that it is usually happens in septic shock, anaphylactic shock, and neurogenic shock. Then there's the transection of spinal cord, anaphylactic shock, septic shock. There is an abnormal distribution. So that is the peripheral circulation is dilated, so that the BP falls down. So distributive shock and obstructive shock. That is obstruction to the systemic circulation, like cardiac tamponade, tension pneumothorax, hemothorax, and pulmonary embolism. So sometimes you may get a combination. You may get a combination of all these shocks. Maybe cardiogenic and septic shock is there, and hypovolemic and septic shock may be there. So you can get a combination, and you have to ask about the history, the scenario, taking a very good history and examination will tell you about the cause of the shock. What are the compensatory mechanisms? The compensatory mechanisms, one is you will get an increase in heart rate, so to increase the stroke volume, and another is increase in systemic vascular resistance. The periphery is constricted, so for shunting the blood flow to the vital organs. The circulation to the skin is it is reduced, so that there is a shunting of blood flow to the vital organs, and the BP is also maintained. So you will get a maintenance of BP with periphery being affected. Peripheral, that is skin perfusion, may be affected. You will get modeling, or you will get periphery cold, and the peripheral pulses are weak. So that is a compensated shock. So in compensated shock, you will get the decreased peripheral pulses, the skin perfusion will be affected, but the BP will be maintained. So these are due to compensatory mechanisms. So you can get an increased heart rate or an increase in SVR resulting in a cold peripheries and maintaining. That is a compensated shock. Decompensated is the BP also comes down. So systolic BP less than 5th centile. And that is what I told in the previous slide. 5th centile, less than 5th centile, it's a decompensated shock. The importance is that should not allow a compensated shock to become decompensated, because the chance for cardiac arrest is more in a hypotensive shock. There is a warm shock also. That is warm shock in early septic shock. You can get a wide pulse pressure. The difference between the systolic and diastolic BP is more, and you will get a bounding pulse and sometimes flash capillary refill. The capillary refill, it's not prolonged, but you will get a flash, instantaneous flash capillary refill. So that is also, it's a sign that the child is going, that in the early phase of septic shock, you can get a warm shock, and later on, at any time, the child can deteriorate to hypotensive shock. So how to look for the capillary refill time? You have to press the feet or the pulp of the finger or the toe, and you release, and then you look for the refill time. Usually it will be instantaneous. If it is taking some time, it means that the capillary refill time is prolonged. So you have to make the environment, that is, suppose the environment is in a environment where there is cold, so you will get, so you have to warm the area and then look for the capillary refill time. So here circulation is 150 per minute, 3-year-old child, regular, and as I have told, this is a hypotensive shock. You should evaluate, identify, and intervene. And it's very important that fluid management is very important in 0 to 5 minutes. So as soon as you diagnose, you came to know that the child is having a circulatory dysfunction, the child is having shock, either a compensated or a decompensated shock, you have to act immediately. So you have to, if the breathing, usually in shock, you'll get an increased breathing. Respiratory rate will be increased, because in shock there is accumulation of acids, and the acids has to go out. So you'll get a increased respiratory rate, and then so you see whether the child is, what about the breathing? If the child is having a hypoxia, is the child having respiratory failure, all these things, then you have to give oxygen, and if there is a saturation is less, the child is in, you have to give a NRM and stabilize the child. And then if there is apnea or bradypnea, you plan. In a child with shock, the child is having apnea or bradypnea, you have to plan early intubation. And you have to put two large bore peripheral IV lines. It's very important. So the first line you will take blood for the CBC, ABG, electrolytes, and the second with a sterile precaution you can take the culture if you suspect septic shock, especially septic shock. And intraosseous, if you are not getting a peripheral line, you have to definitely put try look for get a intraosseous line. Is even if sometimes the periphery may be collapsed, you may not be able to get a peripheral vein. Sometimes then you have to give an intraosseous line and start giving fluids. And you give fluid, and gradually you will get the lines, and then you can get the peripheral lines. So do two large bore IV lines. The initial is you have to for resuscitation, as well as you can collect blood and start resuscitating, and then you can subsequently after some time you can do the second for culture, and then start antibiotic if septic shock is suspected. That is very important. So you have to find out the cause for the shock always. In between, you have to find out the cause. By physiological status, you have to find out what is the stage of the circulatory dysfunction, and at the same time, you have to find out the cause for the shock. And if it is septic shock, you have to start the antibiotic immediately. The starting antibiotic as early as possible definitely will have a good prognosis in the management of septic shock. Then correct hypoglycemia. Usually you will be doing, you have to do RBS, glucose sticks, and you have to see what is the blood sugar. And if there is hypoglycemia, you have to treat. And hypocalcemia, if you are suspecting or when the results come, also you have to give treatment for hypocalcemia, because that can otherwise affect the circulatory dysfunction. And in the next 15-20 minutes, you have to give fluid. So after the initial giving oxygen, NRM, stabilizing the patient, putting an IV line, starting antibiotics, and correcting hypoglycemia if any, then you have to give, it is the time for the fluid. Next 15 to 20 minutes, you have to give the fluid. So you have to give isotonic fluid. There is isotonic fluid. The usual isotonic fluid available are the normal saline or ringer lactate. So ringer lactate is having less chloride content, and it is preferable. Some say that it's preferable, reduces the acute kidney injury. And anyway, whatever is not a problem for managing circulatory dysfunction or shock, you have the usual fluid available is normal saline. You can definitely give normal saline. Both are same for the management of shock. And push-pull technique if the child is hypotensive. See, if the BP is low, less than the fifth centile, you have to, child is in hypotension, and you have to definitely give the fluid, that is 20 ml per kg, 20 ml per kg fluid by a push-pull technique. And if the child is not hypotensive, definitely you can take time, 15 to 20 minutes. There is no urgency in giving fast in a child who is not hypotensive. That is in a compensated shock, there will not be any hypotension, and you can give the fluid slowly. But always, when you give fluid, always you should give with close monitoring, especially in a child with anemia. If the child is having anemia, severe febrile illness, definitely you have to give it with a close monitoring. What all things will you look for? You should look for the respiratory rate, should look for the pulse rate and pulse volume. What is happening to all these things? Usually in a shock, the respiratory rate will be increased, the pulse rate will be increased, and pulse volume will be low, and SpO2 will be less. So urine output. So all these things. So you have urine output. So all these things you have to look at. So you close monitoring, mainly liver size, and whether the child is becoming more dyspneic, whether the respiratory rate is increasing, whether the pulse volume is coming up. You are getting a good pulses. Periphery are becoming warm. So all these things you have to monitor the child. You have to also look for whether the child is worsening also. Sometimes the child will worsen, say they become more dyspneic, especially in a cardiogenic shock. So in a cardiogenic shock, if you give fluid fast without monitoring, sometimes the child may be becoming dyspneic, and the heart rate will increase, and SpO2 will come down, and there will be hepatomegaly. So all these things So you have to with close monitoring, whatever your fluid you are giving, whatever is the condition, you have to give close monitoring and look for the response. So it should be response. Next fluid depends on the response to this fluid. So another thing is that in dengue and severe acute malnutrition, you should give slow infusions. So so I'll come to the fluid rate. So dengue and SAM, it is not 20 ml per kg over 15 to 20 minutes. So dengue, it will be 10 to 20 ml per kg over 1 hour. And severe acute malnutrition, it is 15 ml per kg over 1 hour. So you have to go slowly in dengue and SAM. So dengue sometimes may be mimicking. We are getting missed cases closely simulating dengue fever. So the dengue is a close differential diagnosis in some cases of MISC. So if you suspect, then if you suspect cardiogenic shock, that is there is a child with heart disease, or you think that you are suspecting, especially MISC, you will be suspecting whether the child will be having a cardiogenic shock. So if you suspect a cardiogenic shock, you have to give 5 to 10 ml per kg over 30 minutes with strict monitoring of all these things. So fluid in other situation, I have already told. Dengue fever 10 to 20 ml per kg over 1 hour, and severe acute malnutrition. So you are getting definitely severe acute malnutrition cases in our hospital, 1 ml per kg over 1 hour. Other fluids, so other fluids, it's not because it is more important, but people tend to use these fluids in place of crystalloids as a second, for the second time. But there is no need for these colloids unless it is definitely indicated. The colloids, people think that there is greater and more. It is true that it will give greater and more sustained increase in plasma volume, but it is not indicated in usual septic shock because it will increases the risk of acute kidney injury, coagulopathy, and death in patients with septic shock. So only colloids are not indicated unless there is a second or third time in dengue hemoconcentration and shock, dengue fever. So only in dengue fever, in dengue hemorrhagic fever 3 or 4, and after 1 or 2 boluses of crystalloids, only then we will go for. So the usual condition, there is no role for colloids. That is what I want to highlight. And 5% albumin, all these colloids, hydroxyethyl starch, 5% albumin only in situation where that is definitely needed. So usually you will go for colloids only, that is a normal saline or linear lactate. And therapeutic goals, this is very important. So what is happening to the heart rate? So you should assess and you should write it down. All these things, heart rate, what is the heart rate before giving the treatment, before giving resuscitating the patient, what is the heart rate, what was the respiratory rate, what about the perfusion and BP, all these mentation, so the mental status, all these things you have to assess before and after, during the 5 minutes, 10 minutes, every time you have to assess what is happening to this. This is the therapeutic goals. Sometimes all the therapeutic goals may not be attained immediately, it will take some time. So you see whether 1 or 2 parameters of the therapeutic goals are attaining or not, and then they show that your treatment is working. And next to, so you have given the initial fluid, and you have with the close monitoring, and you decide whether the child is improving or not. So you can decide whether, or the child is worsening. So whether, or not much response, but there is child is not worsening. So he can improve, or he can not improve but not worsening, or worsening. So you have to note. So look for the endpoints reached. If reached, continue monitoring. There is you can stop the bolus and you can go with the maintenance fluid and whatever oxygen and all these things you can step down. So all these things you can do. Endpoints not reached but no worsening, then you can give the next bolus. And if the response is plus but not adequate, and you can go up to 60 ml per kg if required. So if at any time if you feel that this is circulation has become okay, then you can stop the bolus and go to the maintenance. When there is a worsening, especially in cardiac, so like and other causes like obstructive cause, metabolic cause, so you'll get a worsening with the next bolus. Cardiac cause, mainly cardiac. So the cardiac cause can be myocarditis, or it can be due to a cardiac myocardial dysfunction due to in septic shock, or due to obstructive cause, or any metabolic cause like hypoxia and acidosis as a part of any shock can result in secondary cardiac dysfunction. So even at the beginning there is improving, but after some time So you can get cardiac involvement secondary to septic shock, secondary to metabolic cause. So you should be careful in monitoring. So if no response with 3 boluses, then you have to start inotropes. That is up to 60 ml per kg. If the child is not improving, you can start inotropes. So, but more than 60 ml per kg, fluid should be only based on the ultrasound or echo. So you have to see the ultrasound, do an ultrasound. Nowadays, ultrasound is available in most of the intensive care units, and people know all the pediatric industries or people working there they know how to look for ultrasound chest. And if B lines are there, indicative of fluid overload. And they have to look at the IVC collapsibility, the inferior vena cava, how it is it collapsible, what is the collapsibility index. And they can also look at the myocardium, cardiac LV function. Is there, what about the ejection fraction? What is the contractility? How well the heart is contracting? So all these things they can assess. Only after assessing these things, then only you can go for more fluids, because in septic shock, sometimes it may require more fluids, more than 60 to 100 ml per kg, sometimes it may require, but only under monitoring you can increase, and always look for the causes of septic shock. So correct these, you have to correct all these things, correct glucose, electrolytes, calcium, and hypoglycemia is corrected by 5 ml per kg, 10% dextrose, and hyperglycemia, if it is persisting more than 1 hour, more than 180, you have to give low dose insulin infusions. And ionized calcium, if the result, ionized calcium is very important. If the ionized calcium is less, you can give calcium treatment. And inotropes, regarding inotropes, how to go ahead for the inotropes. What the inotropes will do, inotropes will increases the myocardial performance. Two things they will do. Some inotropes will increase the myocardial performance, some inotropes. So all the inotropes will have both these action, myocardial performance and action on the peripheral vascular resistance. So if you give increased myocardial performance, you will increase the cardiac output. So if you are constricting the peripheries, you will increases the flow to the vital organs. You can increase the flow to the vital organs. Sometimes when there is an increased peripheral vascular resistance, the circulation to some organs may be affected. So you have to decrease the peripheral vascular resistance also. I'll come to that. So the inotropes, what it will do is it increases the myocardial contractility and also have effect on the peripheral vascular resistance. You have to select the inotrope based on its performance. Each inotrope, the myocardial performance and the PVR, the effect will be different. So the dose you can calculate by 3 into body weight in 50 ml of D5 or NS, and you give 1 ml per hour gives 1 microgram per kg per minute. So that is the. So usually you will have chart. Most of the intensive care unit, they will have the chart how to make these preparations, how much it will give, and what is the dose. All these things, most of the otherwise on other places we can definitely provide. And length based, the pulse program, they have a length based. Sometimes you may not be able to measure the weight of the child has come very sick, so you have to, based on the length and color coded tape, you will have a ready reckoner. You can look for the dose of the drug and size of the equipment, the endotracheal tube and the dose of the drug. So that is available with the pulse. And so usually you will give the inotropes based on whether it is a cold shock or warm shock. Cold shock is, that is the stroke volume is less. So the myocardial performance is affected, the stroke volume is less, and the periphery are cold. And warm shock, there is a peripheral vascular vasodilatation because of the decreased vascular tone as a result of bacterial toxins. Usually happens in septic shock. So when there is vasodilated, you will get a wide pulse pressure and a flash capillary refill. And in the initial phase, later on you will get a hypotension also. So you will get a wide pulse pressure. So usually in a cold shock, you will give adrenaline. Previously, we are used to use the dopamine. Nowadays, dopamine is because of so many problem, dopamine is not used. And in warm shock, will give norepinephrine. That is, it will increases the peripheral vascular resistance. So we can use norepinephrine in warm shock and epinephrine, that is adrenaline, in cold shock. Then this is the table which shows you about all the inotropes. So So you have to be familiar with the dopamine is usually not used. Dobutamine is mainly increases the myocardial contractility as well as decreases the peripheral vascular resistance. So in a cardiogenic shock, you can definitely it is the inotrope of choice to start with in a cardiac shock, cardiogenic shock. And of course, if there is not sufficient improvement, you can add on milrinone. And norepinephrine, it is usually used in warm shock. That is when there is to increase the pulmonary, peripheral vascular resistance. In warm shock, you can use norepinephrine. So this is the dose. So which inotrope to use? So dopamine usually is not used because it is arrhythmogenic, decreases the lymphocytes, prolactin secretion, TSH, not usually used. And it is dose dependent. So in a dose where it produces a increase in cardiac contractility, so you have to use, it will produce vasoconstriction also. So the dopamine is now not used in intensive care units nowadays. The drug usually used is adrenaline. So when there is a cold septic shock, you will give adrenaline. Also in a cardiogenic shock, whether the BP, when the BP has come down. So the cardiogenic shock, the BP has come down, or in a cold septic shock, adrenaline is the inotrope to use. And norepinephrine when it is a warm septic shock, and dobutamine in a non-hypotensive cardiogenic shock where the BP is maintained, you can give dobutamine, and septic shock with myocardial involvement. There also you can use dobutamine. So milrinone, cardiogenic shock not responding to dobutamine or septic shock with the increased pulmonary peripheral vascular resistance. So you have to look at the periphery, and if you want more circulation to the periphery, you can use this dobutamine and milrinone in case of septic shock. So this normal BP. So in a cold shock, you have given adrenaline, and the BP has become normal. Then what you will do? Normal BP, but the cold shock is persisting. Tell the starter on epinephrine, cold shock is there, BP has come to normal. Then you can add milrinone or dobutamine or levosimendan. That is, peripheral, it decreases the peripheral vascular resistance. So the cold shock, that is the peripheral circulation is effective. So you can give this thing and increases the peripheral circulation. So the low BP, cold shock, low BP, still it's low BP even after adrenaline. There you can use norepinephrine because norepinephrine increases the BP, and for cold shock you can use milrinone or dobutamine or levosimendan. And low BP with warm shock, already on norepinephrine, you can add vasopressin. Okay, if it is a persistent catecholamine resistant shock, then you check for other causes. Is there any cardiac tamponade, there is pneumothorax or intra-abdominal hypertension? And it's a refractory shock, there is a role for ECMO. If all the measures fail, you have to treat definitely what is more important is you have to treat the cause for the shock. So all these things like hypolemia, hypoxia, acidosis, all these things, we'll look for the VBG, we'll look for the electrolytes, we'll look for the RBS. So if anything is there, you have to correct all these things. Then toxins like tamponade, tension, pneumothorax, I have to look for, and trauma. And cardiovascular problems due to acute COVID. So you can get myocarditis, acute heart failure due to myocarditis, arrhythmias and thrombosis. And acute in a child with chronic heart failure, you can get an acute heart failure due to COVID. And drugs used in COVID like HCQ can produce arrhythmias, and remdesivir sometimes produces a low BP. I'm not going into all these details. You have to look for arrhythmias and treat. That is what I mentioned in these slides. I'm not going into the details. This is in pulse. You have to look for whether there is an arrhythmia or not. Is it a low normal QRS? Is it a wide QRS arrhythmia? And you have to. So the important what I want to highlight is that you have to look for the ECG abnormalities. Any arrhythmias is there. So to look at the neurological examination, the sensorium is affected. In COVID, we are seeing a lot of cases with the encephalopathy. MISC also presents with the encephalopathy. So to look at the sensorium of the child, is the child having seizures, altered sensorium, and pupillary reaction, whether he is in raised ICT producing phoning, and exposure. the head to foot examination is very important. As I already told, look for the rashes, conjunctivitis, subconjunctival hemorrhage, and any focus of infection and any features of dengue or scrap. So I will end with this discussion after giving actual case scenario how we managed, and we'll stop the discussion. So this is actually a child brought 2 days back to our hospital. So this 11-year-old child, female child from Punalur, is a normal child, normal development, fully immunized child, and pain in the neck and worsening while moving the head. So that is the complaint. And throat pain, swallowing difficulty, and high grade. All these are having for the past 5 days. Child was having all these complaints: high grade fever, swallowing difficulty, throat pain, and pain in the neck. And local hospital, they have given azithromycin, paracetamol, and then child started developing vomiting, abnormal behavior, and abnormal talk. And thought that the febrile delirium, and the child was referred, and because and we thought because this not coming down even after the fever has subsided, or we thought it's not looking like a febrile delirium. We thought of the possibility of encephalitis also. So the body pain, there is inability to bear weight for the 2 days. We thought of any Guillain-Barré like presentation, and the reflexes were on the lower side. So whether there is a GBS like presentation. And there is a history of voice change, nasal regurgitation, and history of showing while walking, and burning sensation both hands and feet. So the cranial nerve involvement, the bulbar symptoms, we thought of a brainstem encephalitis, any nasal regurgitation, voice change was there. So we thought of all the possibilities. And so the child was a pediatric assessment triangle. I mean, child was lethargic, irritable, and spontaneous breathing was present, but the child was pale. And this is the actual record. All these things were recorded by our residents. So the airway is patent. Respiratory rate is 30 per minute for a 11-year-old child. Definitely is having tachypnea. Nasal flaring is there, but there is no retraction. And the SpO2 is 98% in room air. So there is a tachypnea with a nasal flaring, mild respiratory distress. And heart rate is 130 per minute, high. BP is 70/40, hypotensive range. Periphery is cold, peripheral circulation is affected. See, capillary refill time 3 seconds. Pulse is low volume, dorsal speed is feeble. So there is central and peripheral circulation is affected, and child is having hypotension, hypotensive shock. And the child is irritable, pupillary reflex sluggish, and plantar there is no reaction, and got a neck stiffness. So we thought of any meningitis, meningoencephalitis, and no epidermosplenomegaly, but there's a hyperpigmented patches over the body. Rashes were there and conjunctival congestion. So we thought of a KD-like presentation of MISC, and given oxygen by prongs, IV fluid was given, normal saline. In view of cardiac dysfunction, we have started the child on 10 ml per kg, slowly, 10 ml per kg, slowly we have given. And what happened is the respiratory rate has come down, and that is minimal, from 30 to 28, and the BP is gradually slightly picking up, and the periphery becoming warm, and pulse, but still the pulse is low volume and dorsal speed is feeble. But there is a reduction in respiratory rate, and BP has started picking up. So it is improved. The child seems to be improving, and child is definitely not worsening, improving. We have given 10 ml per kg, and the heart rate has come down. That is also very important. The heart rate coming down is also very important. Respiratory rate coming down, heart rate also come down, and BP is picking up, and periphery become warm, and capillary refill time is has improved, and child passed urine. And 3% saline, and we have given, because the child is still having altered sensorium, we thought of a primary encephalopathy. That is a problem to the CNS due to MISC also you can get, and encephalitis also. So we have given 3% saline for the raised ICT, and started ceftriaxone and acyclovir. The important thing is that you have to treat the not only shock, you have to see what is the cause of shock also you have to treat. You have to see treat other things. The breathing, if it is there, you have to treat the treat for breathing problem. and then neurological dysfunction, raised ICT, seizures, all these things also you have to treat. So you have given treatment for that, then again given on 10 ml per kg, and there is the BP is not picking up, it is remaining the same, not much improvement, it is remaining the same. So the child is shifted to the PICU for further management. We have made secondary assessment. We thought of brainstem encephalitis, GBS, MISC, and we have done investigations, and investigations were suggestive. So initially we thought of all these possibilities. So you have given IVIG, and later the investigation revealed it was a MISC. So in PICU, child was reassessed, one more bolus, and given inotropes. There we have started the child on inotropes, and initially with noradrenaline because there is a wide pulse pressure, and then added adrenaline, and because the LV showed LV dysfunction, cardiac cause is also there. We have added dobutamine. With the 3 inotropes, child circulation has become better and has become normal. And the CPAP, we have the child CPAP is changed to non-invasive ventilation, and so this is how we manage the case. And just to show how, because transport, I'll say spend 5 minutes for the transport. That's very important. Transport goals are optimize and stabilize cardiopulmonary dysfunction, and prevent secondary organ injury, and identify and treat the cause of illness, and minimize the risk of deterioration during transport. Child should not deteriorate during transport. You have to stabilize the child and send the child. Otherwise, the neurologically intact survival, that is very important. So neurologically intact survival is very important. So if you are not transporting, after stabilization, you have to transport in that stabilized form. So all the things, what are the infusion, if it is there, ventilatory support, it is there, anything, whatever is there, you have to continue all these things, and you should try during transport. So continue monitoring infusions, maintenance fluid. So only after intravascular volume is restored, you have to go on to the maintenance fluid with potassium added and fluid rate for the maintenance rate. Then you can, this child was transported, intra-hospital transport to the PICU. And sometimes you may need a inter-hospital transport. To other hospitals, you need transport. Transport decisions, you have to prepare for the transport. You have to see what is the mode of transport you are looking, you think of, and you should have a transport team. That is very important. You have to previously, if suppose a child you want to shift, you have to previously have to make a team. So this team is going. And then communication. You should communicate with other hospital, and post-transport follow-up is very important. So advanced preparation is very important. So not only immediate preparation, most of the time you'll have immediate preparation, but advanced preparation is very, very important. So you should know what are the list of facilities providing tertiary care center, tertiary care with the phone numbers and alternative facilities. So where all your child, to which hospital the child should be transported according to the problem of the child. So then local transport system and their pediatric capabilities. Some ambulance, they may not have pediatric ventilators, pediatric thing. So you have to know which ambulance is having this pediatric capabilities. Then periodic evaluation of the transport vehicle. That is also important. And equipment to be carried, administrative protocols. Then immediate preparation, documentation, consent should be there. The charts, they should have a chart while on when the child is transported, and with all the X-rays and lab investigation from that hospital also you have to carry when transporting the patient. And secure airway, fix ET tube and IVs, and stabilize cervical spine and any other. Anticipate the need for blood products and drugs supplied. So never transport in a caregiver's vehicle is not an option. So transport team consideration, all these persons should be informed. Transport communication, physician to physician, and document it. Nurse to nurse, provide history, treatment given, current clinical status, latest change in clinical status. To family, update all the interventions and studies, answer questions, clarify information, and offer comfort. And provide post-transport follow-up, provides important feedback that can improve the performance of transport team and referring hospital. There should be a communicating with the referring physician and receiving physician. So when you during transport, you deliver the not only the patient but patient information in optimal condition. Thank you very much.